Welcome to this episode of Morning Report Emergency Medicine. I'm Alec Weir. This is the case of can't stop, won't stop. A 68-year-old man with a history of epilepsy is brought in actively seizing. He's been pulled out of a car in the parking lot. Someone else drove him, but that person couldn't stick around, so they're gone. And when he's brought into the emergency department, his head and eyes are deviated to the left with rhythmic jerking of his upper and lower extremities. He's seizing. For our resuscitation, we have no vital signs. The blood pressure cuff doesn't fit on his arm well while he's jerking. The pulse ox won't stay on. Difficulty obtaining IV access, so he gets drilled. An IO is placed. 4 milligrams of Ativan are given with continued seizure. A repeat 4 milligrams of Ativan are given. He's loaded with anti-epileptics, and he's intubated for airway protection. Now it's real easy to get a set of vitals, right? His temperature is 38.1. He's febrile. Heart rate of 84. Respiratory rate of 20. Blood pressure of 132/64. Satting 100% on the vent. So what evaluation do we need? Well, we're going to get our lab workup. We're going to do a sepsis evaluation, right? He was febrile. Could be from the seizure. It could be what caused the seizure, which includes a UA, chest x-ray, EKG, and a CT head. Chest x-ray here, you can see he's been intubated, and we've got a bit of a consolidation in the right upper lobe. Concern for aspiration pneumonia. CT head, no acute intracranial abnormality. Lots of other stuff. Chronic microvascular ischemia. Severe global atrophy. Nothing acute. He got antibiotics for his aspiration pneumonia. He got thiamine and folate because chart review says he's got a history of alcohol abuse. He got rectal acetaminophen for that fever of his. And he's on a propofol drip for his sedation. We've got status here, right? And what's our definition? How do we know? This is continuous convulsive activity for greater than 5 minutes, or recurrent seizures without a return to baseline in between. And we didn't know. He was about 5 minutes by the time he got intubated in our department, but he came in seizing, so we didn't know how long it had been lasting for. Approximately 22% mortality for status across the board. You got to know your causes, especially in a patient without a history of epilepsy. Things like infection, intracranial hemorrhage, metabolic disturbances like hypoglycemia, hypo or hypernatremia, uremia, structural abnormalities like aneurysms, mass lesions, or congenital defects, toxins like cocaine or alcohol withdrawal, as well as trauma. And I'll add it at the end. Refractory seizures. Patient could be on isoniazid. Get him that pyridoxine. You're welcome for that test point question. So what are our treatments? First line, benzos. Lorazepam, 2 to 4 milligrams IV. Your second line, fosphenytoin, 20 phenytoin equivalents per kilogram, or you can go right to phenytoin, which is 20 milligrams per kilogram. You're going to notice a recurring theme with the doses here. Third line agents, valproate, levetiracetam, or phenobarb, those are all 20 mg per kg. Or you can go to propofol. And then your fourth line agent is to use one of the third line agents you haven't already used, or a general inhaled anesthetic. His EEG, which was done emergently, showed no electrographic seizures, but it did have some abnormalities with delta to theta slowing. What are our take-home points? Know your definition of status, greater than 5 minutes of seizure activity or not returning to baseline. Know the treatments, your first, second, and third line drugs, and that rule of 20s when it comes to doses. And know your causes. If you don't have a history of epilepsy, you got to be concerned for infection, intracranial hemorrhage, your metabolic disturbances, structural abnormalities, toxins, and traumas. Thanks for listening, and keep your eyes open for more interesting cases.